All right. Hello, everyone. Hello. Welcome to OBHealthy, the Doctor's Lounge. We're a group of Black physicians that are here for two main reasons. And the number one is to increase the medical knowledge of people of African descent. Number two is to encourage young Black males to go into medicine because we really need them. Our webinar comes on every second Saturday at 1 o'clock. And please tell family and friends because it takes a village to make something like this, successful. If you want to see our past webinars, you just have to go to OB Healthy and look at our YouTube icon. Just click that. Or if you go to the doctor's page, there is a little image of a camera, and just click that, and you will be able to go to our YouTube channel and you can see any of our past webinars. Please check them out. A lot of great information there. Please subscribe to YouTube so we can continue to bring this to you in that format, please. All righty. What I'd like to say is, and this probably is the most important thing that I will say all day, is please do not change any aspect of your medical care until you consult your physician. Only your doctor, believe me, only your doctor can truly treat you appropriately for your medical problems. All righty. I'd like to introduce the docs here, and I'll let them introduce themselves. Dr. Court, you're first. Can you introduce yourself, please?
Good afternoon to all. This is Dr. James Court. My practice is located in East Orange, New Jersey. I'm an internist, meaning I treat adults only. No kids, no surgery, no GYN.
Excellent, excellent. Thank you. Dr. Clevin Clark, please.
Good afternoon, Dr. Kevin Clark. I'm a surgical oncologist. I work at a New York Cathedral.
All right, thank you. And Dr. Jordan Garrison.
Good afternoon. My name is Jordan Garrison. I'm a general vascular bariatric surgeon and feel privileged and honored to be here.
All righty. And Dr. Atherley, please.
Hi, good afternoon. My name is Trevor Atherley. I'm an interventional cardiologist. I work predominantly out of Newark Methodist Medical Center.
All righty. And I am Dr. Omar Bey, pulmonary critical care with a subspecialty in nutrition. And I am pleased, overjoyed to be here with these physicians today. We are privileged that we have one of our own that is highlighting a topic. And our topic today is veins, arteries, and circulation. And understand our veins and arteries carry just about every nutrient that we need to survive. So they have to work for us in order for us to keep living. And we're going to approach some of the things that can go wrong with our veins and arteries and see what we can do about helping everyone from that aspect. Well, Dr. Jordan Garrison is our guy, and he's the one that's going to, and he's the one that's going to open up for us. Jordan, would you like to start off with the slideshow, or do you want to?
Well, yeah. Why don't you cue it up and then I can fill in some blanks and everything.
Okay. Okay, we'll do. Just give me one moment.
Okay. Well, I'll talk while you're working on that.
Okay.
One of the things that I'd like to do is talk about arteries and veins and break it down in such a way that is in layman's terms, so everybody can understand, as opposed to using the big doctor terms and things like that. Arteries and veins, it all comes under the guise of peripheral vascular disease. And what the first distinction that has to be made is when patients come in the office, they said, I have bad circulation. Well, there's two parts of circulation. One is the delivery that the blood vessels have of oxygen. Oxygen is the main nutrient of the body, and we want to make sure that we deliver oxygen. That is typically what we refer to as circulation or arterial disease. On the other end of that is the blood has to get back up to the heart to go through the lungs to be pumped out again with oxygen. That is the function of the veins. And so when we're talking about peripheral vascular disease, we're going to divide it into those two categories. arteries, delivery, and veins or return. So next slide, please. What are we talking about? We're talking again of peripheral arterial disease or the arteries, peripheral venous disease. And also, this is Dr. Court's and Athley's forte, coronary artery disease. And then we have aneurysmal disease, which means ballooning of the arteries. And then we have cerebral and carotid artery disease, which is the blood going to the head and circulation in the head. And then renal vascular hypertensive disease, which gives rise to kidney failure, high blood pressure, et cetera. We're going to focus mostly on the delivery system, peripheral artery disease, and peripheral venous disease, or problems with the return of the heart. Next slide, please. Okay, just some prevalence. Males have a greater prevalence than females of this, and 10% of people over 60 years old are going to have delivery problems. African Americans double the rate of all other ethnicities, and there's reasons for that. Some of it has to do with selection process that happened during the Middle Passage. Some of it has to do with the way our lifestyles and just the stress of living in this America as we know it. And it's higher in high-income countries because of the diet. High-income countries tend to have a richer diet, a diet higher in fat, higher in processed stuff, and lower exercise rates. Why? Because we don't have to walk. We have cars that take us everywhere and do everything for us. Okay, next slide. Okay, risk factor. Number one risk factor in both arterial and venous disease is smoking. You know, in the 1960s, 30% of the American population were smokers. I think we're down to about 11% now. Diabetes is another big factor. Diet, what we put in our system. Obesity, we are at epidemic proportions in this country of people with obesity. Alcohol use, high cholesterol, part of it is heredity, lifestyle, and there's some other chemical alterations in our body, which we're not going to go into right now. Next slide, please. Mostly our focus is going to be on the lower extremities. Basically, you have a main artery, the aorta. When it gets down in the groin, it splits into the left and the right side. The left side and the right side are pretty similar. We have a main artery called the femoral artery that goes down. When it gets below the knees, it splits into three different arteries, the anterior tibial, perineal, and the posterior tibial artery. And those are responsible for delivering blood flow to the leg. Next. Now, the biggest problem in peripheral artery disease is the development of plaque, which gives rise to narrowing of the arteries, which gives rise to arterial circulation problems. And basically, the artery has several layers into it. There is deposition of fat or cholesterol that goes into what is called the media or the middle portion of the artery, and it fills up and eventually it calcifies, and then it occludes the red blood cells which carry oxygen. The delivery system is compromised, so therefore you're not getting enough red blood cells into the areas that need it. Next. And this is just some cross sections of the plaque that we have taken out, and you could see how the artery is narrowed underneath, and that's the deposition on the right-hand side. That's something we might take out of the carotid artery to increase the blood flow, but you can see the disease process that goes on. Next. Okay, when we talk about peripheral artery disease, we talk about two distinctive entities. One is called claudication. That means you give a certain effort, you develop pain, and when you stop that effort, it goes away. That is significant that you have some disease. And it's about lifestyle. We use the word disabling. Okay, the people that go to the mall and they say they walk the mall, they get pain in their leg, and then they got to sit down and they got to go to Macy's. That is not disabling, because they can sit down and relax for a few minutes. But for instance, the mailman who is delivering mail, and all of a sudden the dog comes out to chase him and he has to pull up because his legs hurt, that's disabling. It is altering their lifestyle. There's another one called intestinal. You eat something and you get this intense pain, and as soon as the food is going through the system, the pain goes away. Limb-threatening ischemia is broken down into 3 phases. Rest pain, typically the patient says, I lay in bed at night and my big toe hurts, and then I got to get up and rub it and scratch it, and it goes away. Well, really what they're doing is hanging the leg down, and more blood goes into the foot because it's hanging down. When they lay in the bed, the foot is elevated, and therefore they're not getting enough blood or oxygen. Tissue loss can be an ulcer, and gangrene is blackening or necrosis or deadening of the skin. So those are the 2 categories. And the treatments are different for those categories. For claudication, next slide, please, I think.
Jordan, one quick question.
Yes,
Sorry
sir.
to interrupt. Go back one slide, Omar. So,
Okay, hold on.
are you able to, so would you say in the description, so claudication and limb-threatening ischemia, we're talking about different levels of obstruction or different the severity of peripheral artery disease?
I thank Kevin for that question. Kevin and I were trained together, so the same question that he's asking me was part of our training. So thank you for that. Yeah, we measure the amount of blood flow into the leg, and what we do is what's called a ankle brachial index, where we compare the blood pressure in the leg to the blood pressure in the arm. When you have, and normally that should be just a little bit above 1, but when it breaks down to certain numbers is indication. When it breaks down to 0.6, which means that the blood flow is diminished, that's typically when you get claudication. And you get it in the back of the calves. That's where people get it. You can also get buttock claudication too. When it gets down to 0.3, which is really severe, you'll start seeing the rest pain, the tissue loss, and the gangrene. So yes, it can be categorized based on that loss. Did I answer that question, Kevin?
Yes.
Or do you want to add to it? Because you know just as much as I do. Okay, so I guess
all right. Jordan, Dr. Patrick Anderson is raising his hand, and I know we can't see each other right now. We only see you.
I see his hand.
But Patrick, hopefully you have your mic on, and please ask your question, Patrick.
Yeah. Hey, Jordan, it's Patrick. How you doing?
All right, good.
So
he got the same training as we did also.
I do. I'm going to ask a little bit more basic than Kevin did. How do you reconcile symptoms as claudication compared to things like capillary refill? So when I see a patient and I examine the toes and it's nice and warm, but I see good capillary refill, but she still complains of calf cramping. How do you measure the amount of blood or that index that indicate that she's getting good blood flow to the leg?
Yo, my brother, you jumping the gun, man. You still
All right, I guess.
Okay.
I guess we should let you continue.
I'm going to
continue.
all right. Give me a second, okay?
Okay. All right.
Okay, next slide, please.
All right.
Okay, here we are. We were talking about the ABIs and the segmental pressure, but every patient that comes in, it starts off with a good physical exam. You can make most of your diagnosis by physical exams, and that's what we do as practicing physicians. We do a history, we do a physical exam, we ask about symptoms, we ask about relieving factors, alleviating factors, and then we do a physical exam, and we direct our physical exam to where that history leads us. And then we order specific studies based upon the history and physical exam. It's not like, hey, let's just order these tests and round up the usual suspects. You know, our exams and histories are directed towards the symptoms of the patient. So the first thing you want to do is check pulses. You want to see if there's a pulse in the groin, behind the knee, in the forefoot, and also behind the ankle. And those are the specific pulses we're looking at. They're categorized as present, diminished, or absent. And so that's the way you go about it. You also look at when the foot is elevated, what does it look like? And when you hang the foot down, does it turn red? Which, as you're talking about, the dependent rubor. And if it all of a sudden gets bright red, that's indicative that you've got some type of arterial or delivery problem going on. Once you do that, then you're going to do some diagnostic studies, and that's where we're talking about the ABI. And you're looking for diminishing of the ABI. And again, claudication is 0.7, 0.6, and rest pain is going to be down to 0.3. And that's pretty severe when you get down to 0.3. Now, once we do that, there's another test that we can do called the duplex. Duo meaning two. It's going to give us a anatomical look at the vessel for first, and then secondly, it's going to give us an indication of what the flow is in that vessel. And so it gives us anatomy and it gives us flow. You do not order contrast studies unless you have decided the patient needs intervention. You don't order contrast studies looking for the intervention. You order it when you know there's an intervention and you just need a roadmap as to where you're going to go. So angiogram, MRIs, and CAT scans are held in reserve until you've made a decision that you're going to do some type of intervention. Now, next slide, please.
All right. Before we go on, you said contrast study. What is that?
A contrast study is a dye. You know, people say I'm allergic to dyes. It's a dye that has a radio opaque substance in it, and that the X-ray machine or the CAT scan or the MRI will see that, and it helps delineate the anatomy. So you know you have a roadmap. Okay.
Thank you.
Okay, and then again, duplex scanning, it's with an ultrasound. At the top, it's showing us the anatomy. Blue means that the blood is flowing towards the probe. Red means it's going away from the probe, okay? And then this is just shows what is called a pulse volume reading of the what's going on in the leg. And this coincides with the arteries. Okay, next slide. Oh, and this is a contrast study. This is showing an angiogram, and it shows the blood vessels as we have delineated. And if you look in the right leg, the right is going to be the left of the screen. If you look in the right leg and you look down below where the knee is, you can see a break in the contrast on the outside. And that is a blockage. That's what the angiogram shows, the blockage. So the other studies would have shown us that you need to do something to alleviate that blockage. But I want to go back to what Patrick's question was about what can we do in prevention. For claudication, the prevention is simply a cessation or stopping of the risk factors. Seeing smoking is the number one thing. We tell the patient, you got to stop smoking. No ifs, ands, or buts about it. Stop smoking is out. The second thing is exercise. People are under the misconception by exercising, you're going to increase the number of blood vessels. The only organ in the body that does that is the liver. But what we do with exercise is we increase the number of mitochondria. Mitochondria are the energy producing substances or structures in the leg. And that's why people can run long distance, is that they've increased their mitochondria. It's like the power factory. And so if you increase the number of mitochondria, you increase the efficiency of the exercises.
Yeah.
So
and the mitochondria is located in each of our cells, right? That's a power.
Every cell has mitochondria in it. You know, it's like putting 10 Omar bays into a leg versus one Omar bay. Okay.
I got you. Dr. Atherley, you have your hand up, please.
Yes. I wanted to ask a question. I'm very pleased that Dr. Garrison, introduced under his heading of peripheral artery disease, coronary disease, because of the close relationship we appreciate that the basic disease process, which causes atherosclerosis or hardening and narrowing of the arteries, can occur in any arteries of similar size throughout the body. So we're always concerned when we have coronary artery disease that we may have other arteries similarly involved, especially the peripheral artery disease as mentioned, or diseases of the arteries involved in the kidneys, or even those to the brain. What I wanted to ask perhaps whether there's a difference in the risk factors that predispose us to depositing the substance cholesterol into the layers of the walls of these arteries. I saw that among the risk factors, smoking was your major risk factor, and I still think that's the same as well for cardiac or coronary artery disease. But alcohol was mentioned. And of late, maybe over the past 15, 20 years, there's been a different attitude towards the use of alcohol in relationship to coronary artery disease. And I want to know if the same obtains for peripheral artery disease. In other words, after a landmark study, which was published initially of patients in France, where, of course, you know, the diet is high in substances which would predispose one to having development of these blockages, but they had a lower incidence of coronary artery blockages than those in the typical American population. And it was felt that a major role was their use of alcohol, which when used in moderation, or what they call moderation, which is 1 or 2 drinks per day, it seemed to diminish the chances of having significant consequences of the otherwise bad diet and less blockage of the arteries than we would have anticipated. And there was a whole big hubbub and a big stir about the value of alcohol. And in fact, we now feel that there are salutary or beneficial effects to moderate use of alcohol. And of course, we frowned upon excesses. But I saw that you mentioned alcohol. I want to know whether the same obtains for peripheral artery disease, whether we're happy to have our patients have a little alcohol, in other words.
Well, I can tell you a story about my grandfather. My grandfather used to take a little 4 or 6 ounce glass, and he'd say, I said, "Grandpa, you're drunk." And he says, "No, I only had 1 drink." And I said, "You can't get drunk off of 1 drink." And what he would say was, as long as the glass isn't empty, it's 1 drink. So, so I think you cardiologists are the leaders in this, and the same factors that you see, we follow behind you. Yes, the studies have shown that moderate use of alcohol, what it does is, like I said, you should have a glass of red wine once a day, because it increases the HDL, or high density lipoproteins, or cholesterol. HDLs are protective in arterial disease as well as cardiac disease, correct?
Yes.
And low density lipoproteins, or bad cholesterol, processed food, and things of that nature, are detrimental to the heart. And so exercises increases HDLs, protective, and they say a glass of red wine every night increases HDLs as well. So if that's what you want to prescribe to your patients, I think it will be beneficial to them. But don't do like my grandfather, okay? Drink the whole bottle.
I think one of the problems with those population-based studies, it's hard to standardize for all of the other factors. For instance, it may be that people who take in more alcohol at a modest level, they may exercise more. So we may be measuring other things indirectly and not so much that factor. It's hard to measure what's a moderate amount, right? What's somebody's moderate, maybe, you know, somebody else's excess. I do think there is something to it. I'm just not sure exactly if we can quantify and say specifically that it's a recommendation.
And to Kevin's point, you know, there's other factors, right? So alcohol, in combination with components of one's diet. So a French diet with a glass of wine with meals and certain other nutrient components versus an American diet with a glass of wine and other types of diet, whether the two in combination will make a difference.
Yeah.
Yeah,
True.
there have been a few other, in fact, it was a source of major study, and there certainly have been some disputes, and I certainly appreciate the comments that you're making because they're all very germane. The thing is that we felt it was particularly important because their diet is more of an atherogenic diet, more the kind of diet that we associate with the formation of blockages, say than the typical American diet. So this was even more extraordinary in that population. The other point I want to make is that although the initial study mentioned red wine, we find that it doesn't matter whether it's red or white. And in fact, even these studies have been extended to other kinds of alcohol where benefits have been shown from other alcohol other than wine. So I don't want to put a boost in for the red wine industry. I just want to say that alcohol as such, in moderation, is a benefit. And those studies have reproduced it in many different studies.
We have Dr. Court's hand is up. Dr. Court, please.
The reason is just wanted to chime in terms of red wine. Having been to France a long, long time ago, usually when you sit there, they bring the wine, whether or not you order it. But I don't know if there were any studies that really documented that red wine or a glass of red wine would indeed increase your HDL.
Okay.
It may be just anecdotal.
No. Subsequently, those studies have been extended to alcohol as such, and not just red wine specifically. So we have seen the benefit of alcohol in those biochemical changes. But again, what is moderation? The point was raised earlier as to what is moderation. What we can all recognize excess, but we're not sure quite what is moderation. And moderation seems to be not only medical, but based upon some sociological factors in the specific societies that we're describing. So yes, it is not a very precise or very scientific conclusion ultimately, except to say, well, maybe there's something to the use of alcohol. But I mentioned that because we previously had thought of alcohol as being detrimental. And in fact, I was looking at one of the studies, these slides, which Jordan showed, and it just mentioned alcohol. So I just wanted to mention that maybe look at alcohol in two different ways.
Well, Dr. Atherley, were those studies extended into the United States, or are we talking about mostly studies from Europe?
We're talking about
Because the Mediterranean diet is over there, so if you kind of put other combinations together, as I think Kevin said, it may get a different result.
Absolutely. There are many different factors that may be influential, but the studies were not only in France and they were not only for red wine, but we saw benefits for whiskey drinking, for example, and beer drinking. I think that was from Germany. So they saw that there were benefits to other forms of alcohol in other societies, but mainly European.
Okay, excellent.
So
Jordan.
I have to follow up on my grandfather because he had pain in his leg from arterial disease, and his correlation with alcohol was like, my foot doesn't hurt when I'm drunk. So
Ahead of his time, yes.
Patrick, you had a question?
Yes. So, this is between the battle between you and Dr. Atherley. I don't know if we need the heart to maintain the integrity of the extremity, or we need the extremity to be able to exercise to maintain the integrity of the heart. But to your point, you don't do a contrast study unless you to look for a lesion. You do a contrast study to identify a lesion when a patient is symptomatic. But the question I ask for you, and this may be my misinterpretation of screening for coronary artery disease, if you can do a CTA to evaluate, a CTA mean a CAT scan contrast study of the coronaries of the heart to evaluate vascular disease, is that an evaluation or a screening? And if that's screening, why can't we do it for the extremity?
Are you asking that to me or to Trevor?
Well, you guys figure it out. Who's fighting over the heart or the limb?
I don't think there's, if the pump doesn't work, you're not delivering anyway. So the pump is primary. The secondary thing is the arteriosclerosis. Now, as far as I can figure out where the disease process is based on physical exam and the ABI, I have an idea. Again, the arterial studies are only giving me a roadmap of where my surgery and maybe the type of surgery that I'm going to do. So that's, I think they're one separate and apart. Also, when you look at screening exams, you got to look at the cost and you got to look at the positivity and the sensitivity of that studies. You know, so a screening exam has to be low cost and give you high results. Henceforth, digital rectal exam and stool guaiac for colon cancer. Low cost, high sensitivity and not specificity, high sensitivity. As far as to do an angiogram or a CAT scan, what is the price of a CAT scan or angiogram now? We're talking about several $1,000s. Whereas I can get basically the same information and knowing there's a disease based on symptoms, based on the ABI, based on a duplex study.
But isn't that
And
being
the physical exam.
Yeah, but isn't that being tunnel vision though? Because if I spend high cost on a study that in my head, and don't misinterpret what I'm saying. I'm trying to reconcile whether you're doing diagnostic study or screening, but the one-time high cost versus the cost of having this process perpetuating over time, and then the long-term cost of the disease once it's developed. I mean, is it a matter of failure to rescue earlier or not? Because I think in this case, the cardiologist is ahead of the game.
Well, let me jump in a little bit to try to extrapolate some of the questioning of the peripheral artery disease and relate it to the cardiac disease. What we're talking about here is the best way of evaluating the presence or absence of significant blockages of the arteries to the heart.
Right.
And if I go back a little bit, step back a little bit to some of the basics of this, the arteries of the heart suffer the same sort of insults that the arteries to the periphery will have when the development of atherosclerosis occurs. We are, however, interested in the quantification and the effect of the blockages, right? So we go through the gamut of evaluating the symptoms that a patient presents with and see whether or not these symptoms may relate to significant blockages of the arteries. We're well aware that the symptoms may not be precisely correlated with the severity of the blockages of the arteries in the heart. So we utilize other means as well. So we go beyond the symptoms to the physical examination, and that they're fairly sparse in terms of physical examination findings that tell us specifically about the presence or absence of coronary artery disease, unless the patient has already reached that stage of dire blockage where he's had a heart attack, for example. There may be some physical findings. Then we go on further to some of the tests that we do, the so-called non-invasive tests where we don't have to put tubes into the patient's body, but where we can test the anatomy and the physiology or function of these arteries in that patient without putting tubes into them, of course. So let's talk about some of those. The simplest is, of course, the electrocardiogram, the EKG as it's often referred to. The EKG is a wonderful tool in demonstrating where damage has actually occurred and where scarring has occurred to the muscle, where we can see major changes on the electrocardiogram. If a patient, however, has not had major damage and has blood flow down the arteries, which is sufficient to serve the needs at the time that the patient is having the electrocardiogram, you lay quietly on a table and you have a technician come and hook you up and do the electrocardiogram or the EKG, it may not show any significant findings, even in the presence of severe blockages of the coronary arteries. And we quantify severity as more than 70% obstruction of one of the arteries to the heart. So it may not show. So we go a little further. If we have a greater suspicion, we decide, well, we're concerned about the balance between supply and demand. The supply of blood to the heart muscle is met through these coronary arteries. They should be intact, widely open, you get a good blood supply. The demand is generated by what the heart is doing. The heart is working hard. You try to run up a flight of stairs or other activities that we can all think of, then this may increase the demand, and we would hope that the supply could be increased. But if you have blockages that are significant, then you may not be able to adequately improve the supply of blood to the heart muscle. Hence, we do the stress test. The simplest stress test is an exercise stress test. We have the patients exercise commonly on the treadmill. Less commonly, we use the bicycle, but commonly on a treadmill. And we monitor the patient's heart and blood pressure and pulse during the time that this test is being performed. And the simple test may show us the development of certain changes on the electrocardiogram, which then suggests to us, the heart is not getting enough blood when it's exercising adequately. And so they maybe need to go in and do even further testing. In the event that we are even more suspicious of blockages, and we feel that the exercise stress test, 70–80% accuracy there, does not give us the full answer, we may do a more sophisticated kind where we give an injection of a nuclear material into the veins during the time that the patient is exercising, and we compare how well the blood is flowing by looking at these pictures, how well the blood is flowing to the heart during the time of exercise or shortly thereafter, compared to when the patient is resting. And we can again get a bit more information and see whether or not there is blockage, which is shown to be significant during exercise. From there, we may go on to, I think you mentioned the coronary CTA, the CT scans, which you mentioned earlier with the periphery. We can do those, but they suggest more the anatomy or structure than actual the physiology or function. I am really more concerned about the function, and then we try to relate the anatomy or the structure to that. But the function is very important. That's why I like the functional test, the stress test more. But the coronary CTA, the CAT scan of coronary arteries, merely is a radiological test which shows us with dye injection, blood and dye flow through the coronary arteries. And we can utilize that to see if there are significant blockages. And we keep going further and further down the road. That's why we don't like to start the testing unless you're prepared to go further. Now, if you see blockages of those coronary arteries, you can decide if they're severe enough to relate to the patient's symptoms or to disturb or affect his function such that you may have to do some corrective measures. Before we can do corrective invasive measures, you may then go on to even further tests. Maybe you don't want to take up your time to get into that, but so-called invasive tests, which is part of what I'm specialized in, where you pass tubes directly into those coronary arteries. You pass them backwards through the arteries of the body, the artery either at the wrist or the artery in the groin, pass these small tubes back into the coronary arteries, the arteries of the heart. And we inject dye, and we can then more accurately visualize the blood flow to these coronary arteries. So we can go further and further with our testing and ultimately make clearer decisions in terms of the treatment. But that is a perspective of the coronary CTA in relationship to the cardiac catheterization that I just outlined.
Yeah.
Just to add one thing, I think one of the things as far as the natural history, I think we have a lot more information with cardiac disease as far as the vessels, the degree of obstruction, the location, etc. With peripheral vascular diseases, it's a little bit harder because you can have the same, to some degree, the same angiogram or similar angiograms in two different patients and have drastically different symptomatology. So the non-invasive component, or as Dr. Atherley mentioned, the physiologic match to what you're seeing on imaging is critically important when you're looking at those features.
Excellent, excellent. You know what we can do, Dr. Garrison, we can go back to the slideshow.
Okay, good.
I just wanted to bring the panel in since we were discussing, and we'll go back right now. Hold on just for a second.
Right.
Jordan knew he wasn't going to leave the panel out.
Okay, next slide, please.
Okay. Hold on, let me get this. For some reason, it didn't go to the next slide. Hold on. Okay.
Again, talked about the treatment, cessation of risk factors, smoking, diet, increase your exercise, and then we get to angioplasty, which Dr. Atherley was talking about, and then we talk about surgical procedures, which I don't really want to get into. Can you go to the next slide, please, Omar, I think?
Yes, I can.
Yeah, I'm going to hand off right now to Dr. Atherley right now, and he can talk about stenting, because this is, you know, people don't really have a concept of what's going on. I thought these pictures would help. So Dr. Atherley, if you don't mind, I'm passing the baton to you.
Okay, as I look at these, I've looked at these for the first time, at the illustrations that you have, as we go in numerical sequence. The first one, number one, shows a buildup of cholesterol, as is stated. And you can see the yellowish deposits in the what we call the subintimal region. That is just underneath the internal lining of the artery. And you can see that in the middle of your number one picture, there is a significant degree of the yellow stuff partially blocking, so that the red pictured portion that you see, I suppose, illustrates blood flow down the artery. And it shows clearly that at one side, the blood flow is greater and the other side also greater than what we see in the middle of that illustration. So having found a severe anatomical defect, by that, again, it may be a difference in terms of what you consider severe in peripheral artery disease, but in the cardiac situation, we consider more than 70% obstruction of the lumen or opening of that artery. So having made the decision that this is severe enough blockage that needs to be fixed, we pass a balloon and stent. In this example, you have number 2, you have in fact a wire passed down the artery from wherever you entered before. You should, at the beginning of the artery, you pass down to the more distant parts of the artery, and over that is threaded a balloon, a catheter with an inflatable balloon, which you can then blow up at several atmospheric pressures, blow it up to squeeze or squash the blockage which we see in that number 2, the yellow blockage, so that you're left with number 3 picture, where we've now restored the opening of that artery, the lumen or the area through which the blood flows, to more like the normal. You can see the difference here, even though in that one, that's at the moment complicated in that picture because you have the balloon still inflated. We've blown the balloon up to several atmospheres. And when you deflate the balloon, you then leave a properly opened artery, as in number 4. In the interim, because we do know of the redevelopment of blockage in the same location again, we've developed over the several dozen years now, I suppose, the stenting procedure, where we not only put a balloon to open the artery lumen or opening so that the blood flow can be increased, what we do is leave a scaffold. The scaffold is called a stent. It's a little wire mesh. It looks somewhat like the wire you see in a ballpoint, the spring in a ballpoint pen, for example. Those of you who still use those. And so what you do is blow that up. It is mounted on the balloon. It is blown up and is then left in the wall, scaffolding or supporting the artery so it doesn't recoil on itself. Of course, there's some complications associated with that, and we have to give medication to be sure that we keep that artery open adequately and be sure that the body does not lay down too much of a deposit of its own material to partially block that stent as well. But in any case, what you've illustrated here is from 1 through 4, a severe blockage involving the artery, which has been opened with a balloon and a stent has been left in position, leaving the artery now opened. This is the same sort of thing that we do essentially for the coronary arteries of the heart once we see that there's a significant anatomical blockage.
And stents can be used in various anatomical situations. I'm sure Dr. Clark can use a stent in treating oncological or cancer problems. I don't know OBGYN where it may be used, but definitely in the pulmonary system, stents can be used. And these same stents are used in the vascular system, both the delivery system and the removal system or the vein side as well.
We can segue into answer one of the audience question at the same time, answer a question. So it says, can you naturally unclog your arteries is the question. And then there's a follow-up to that. When can we use medical treatment as opposed to doing something from an interventional status? Looking at the picture, when would you decide, Dr. Athley or Dr. Garrison, to apply medical therapy potentially versus an interventional procedure?
Well, for us, one, the medical for peripheral artery disease is limited, and you have to divide it into acute or chronic, something that happens right now or something that's been going on. If you get a acute arterial blockage, there are medications that you can give to take care of that blockage. In a chronic situation, because that plaque is there, I don't know of medications that will reduce that plaque. What we can do is give medications that prevent the platelets from clotting, which could give rise to further disease on an immediately if you had an acute situation. It's the same thing in the heart, whereas if you have an MI where you get an acute clot in the heart, there's a whole protocol where they get people into the emergency room, get them to the cardiac catheter lab. They can give medications to relieve that blockage, and then combine that with stenting. And again, Dr. Athley can talk about that more. But in the peripheral system, we can do that when we have acute problems. We can give medications, we can use a catheter with a balloon in it and try to pull the clot out, and then give heparin, blood thinners to try to do that. But medication alone, once the damage is done, arteriosclerosis, the medication really does not have a major role in long-term therapy of chronic arterial occlusions.
Dr. Atherley, your hand's up.
Yeah, I know. Since I had been partially asked the question, I don't only think of them as one versus the other, but I may think of medication, period, for most of the patients, and then the question of whether, in addition to the medication, we require these invasive type procedures. Let me follow up on the excellent way in which Dr. Garrison has divided acute versus chronic. Now, the example that is still on the screen of one is showing what I assume is a chronic development of blockage of the artery, where that fat is deposited over a variable period of time, over many years most times, into the wall of the artery. And during the time of that development, it may cause symptoms. Patients may have what we call angina pectoris. That's a kind of discomfort or pain, usually in the center of the chest, which occurs more predominantly on exertion and may be relieved by rest. It sounds a bit like the peripheral artery disease symptoms, doesn't it? Well, angina pectoris may be developing over a long period of time as a chronic problem. The acute problem you talked about is often identified as causing myocardial infarctions or heart attacks. And what may happen is that plaque, the plaque is the term we use for the buildup of the fatty tissue into the vessel, that may rupture. When it ruptures, it releases not only some of the fatty tissue there, but it does cause an inflammatory response where platelets, a component of the bloodstream, start to clump together. They start to aggregate, and they continue this process with clotting of the actual other blood components, so that we not only have that yellow stuff, as you exemplified the atherosclerosis, but you now have a full red, full clot, which in the setting of an acute heart attack or myocardial infarction totally blocks, not a gradual blockage, but totally blocks the vessel. Then we may have the acute emergency called an acute myocardial infarction or a heart attack. That is where we have to spring into action rapidly. Patients obviously should come to the emergency room when having a heart attack. It should be identified, and if it is one of the more serious kinds of heart attack called a STEMI, you may hear an announcement in hospitals, STEMI, urgent STEMI, and we have our teams designated, the hospitals that so do this procedure, designated to take immediate care of this. We have a cardiac catheterization lab, which will be prepared with the appropriate staff and equipment, and the doctors on call or present in the hospital as a part of this team will go in and do cardiac catheterizations or pictures of the arteries to the heart, because you make the diagnosis very quickly. We have all the other non-invasive tests that suggest, yes, this is a heart attack in progress. In progress, we have to go and deal with it as quickly as possible, because one of the favorite statements of the cardiologist is that, in the heart attack, time is muscle. The longer you wait, the more heart muscle you lose, and you lose irreversibly. So we have to get in there quickly and try to halt the process as it is ongoing. So in the acute setting, in the setting of an acute myocardial infarction, the blocking material is thrombus, usually, that is clot, fresh clot, not only the fatty substance, but fresh clot. And we go in and we try to remove the clot. Nowadays, of course, we go in and do what's called angioplasty and stenting, as I showed you, although if that is feasible. In other centers where it may not be feasible, we may give thrombolysis, that is medication which we think can dissolve away those. But wherever there is, it is preferable where there is the potential for going into a cardiac catheterization and quickly getting into that clot, and sometimes removing it partially, yes, but importantly, putting a balloon and stent in there to reopen that artery. That is important as quickly as possible.
Excellent.
Kevin, I think you answered the question that somebody asked about ongoing prophylaxis or medications, or do you want us to? What do we do to prevent the stent from closing? I think Dr. Athley talked about it. There are medications, anticoagulant medications that we get, and then a reevaluation in a frequent periodic time frame.
Yeah,
I wanted to mention one other thing about medications to prevent or to reverse this. There, at one point in time, there was a lot of discussion about chelation, and using of EDTA to change the ionic structure of the molecules and help for preventions. That has not really borne out to be preventative or to stop ongoing disease, but it was popular at one time that people were doing this chelation therapy. Anybody else have any information about chelation?
Yes, there's some renewed interest in that, but I'm not sure that there's enough scientific evidence to use it as a mainstream way of treating those blockages. No, I'm not doing that yet.
All right. Want to move on, Omar?
Yes.
Okay. Next slide. And we could talk about the results of stenting there versus bypass, and these numbers, depending on the study, both of them are, I would say, equally good depending on where it is, what the disease is, and the whole characteristics of it. I think it's good. As far as things that cause these either stenting or bypass to fail, if a person continues to smoke, if they continue not to exercise, if they continue to have a diet high in fat and visit Burger King on a regular basis, those types of things cause failure in the long term. And the older you are, the more prone you are for these things not to work. But overall, the success rate with these types of interventions, whether it be stenting or surgical bypass, is very, very favorable.
I think even though we're not going to go into the details, I think it's too much for today. We should mention when we would do surgery, meaning bypass, versus when an interventional procedure will work. I mean, certainly in the cardiac literature, this is, I don't know if it's controversial or not, but certainly there's always a battle between the heart surgeons and the interventional cardiologists. Triple vessel disease, should you stent or should you operate on them? I think that's becoming more of an issue now also with the peripheral vascular disease. Do you do a surgical bypass procedure, or do you do something more limited with an angioplasty and stent? And I think it's a huge topic, I know, but I think we should probably just at least mention something as far as how we make that determination.
Well, I think the first and foremost is a conversation with your patients. What their wishes are, and also to look at your patient too. One size does not fit all. If the patient is debilitated, if they're older, you might want to try to do a less invasive procedure. As with any surgical procedure, there is a certain amount of rehab associated with it. If you're making large incisions on legs to do bypasses, you're taking veins to bypass this blockage, there's a morbidity. Although it may be short term, there is a morbidity. And if the patient cannot participate in their rehab to adequate, then I would lean more towards trying to do a less invasive procedure where they can get up and get about, and we can have physical therapy. The other thing, when I just took my surgical boards, there was a large portion of that learning about care of the elderly patient as our population ages. And one of the things that they said is the most important factor for survival after an intervention is preoperative preparation, that the patient should be on a preoperative exercise program. That's the only thing that really showed significant benefit to their success rate. So if the patient cannot participate in a preoperative program, then you might want to figure a lesser intervention than a greater intervention. And I pass off to Dr. Atherley in that regard as well.
Yeah, well, if I take the baton, I'd like to first of all reply to Dr. Clark, my good colleague, to say that in the rivalry that exists between cardiologists, interventional cardiologists, and cardiac surgeons, in terms of who should have what, that it really is not much of a battle now. I think we've won the battle. But anyway,
You won.
interventional cardiologists. More and more, we're dealing towards the more complex blockages, the more complex lesions. We're finding better means of being able to invade and perform these than having to require open heart surgery. So the frequency of open heart surgical procedures is certainly diminishing. But there are still very, very clear-cut and rigid examples of when one should do what. I agree with Dr. Garrison that most times we would consider, the way we look at it is to consider mostly an interventional or a cardiac stenting type procedure. And if we feel that the patient is beyond that level or has a more severe form of disease, then we consider bypass surgery. For example, if we talk about triple vessel disease, there are actually 2 arteries of the heart, not 3, but one of them divides into 2 major branches. So you may often hear about triple vessel disease, 2 on the left and 1 on the right. If the major artery, the left main coronary artery, as well as other arteries, the branches that come off from that or from the right, if we have severe triple vessel disease, there's more of a tendency to consider surgery. But there are some specific anatomical factors that we discuss with the surgeons and try to arrive at some sort of mutual agreement as to whether or not the patient, and again, we look at the overall characteristics of the patient, as Dr. Garrison has pointed out, it's not just the anatomy of the coronaries, but the patient as a whole. We then make the decision as to whether to subject the patient to major open heart surgery with all of the attendant risk of surgery and the risk post-surgery, compared to that of an interventional approach where we do, without having to make big cuts and all of that, we barely do pass a tube through the arteries in the body up to the heart, and we do the coronary stenting and hopefully avoid the need for bypass. So there still are some clinical situations under which it's clear-cut, but there are many situations under which we still have reason to discuss and debate and arrive at a technically appropriate decision.
Excellent, excellent.
Next, Dr. Omar, I think we've come to the end. I mean, we can go into the weeds about cerebral artery, carotid artery, or renal arteries disease. But I think it'd be an appropriate time to move on to venous disease and maybe take a short break if you want.
Yeah. What I'd like to do is I'd like to do some halftime and then let's answer some questions and then we'll go into venous disease. Is that good?
That sounds perfect.
All righty. So as far as, let me get my act together here. Hold on. As far as our second half, what I'd like to do is I'd like for each of the physicians, and I'm going to pull this screen down. I'd like for each of the physicians to reintroduce themselves. And it's good to see you guys again. Dr. Atherley, please start off, please.
My name is Trevor Atherley. I'm an interventional cardiologist, board certified in cardiology. I'm based predominantly at Newark Beth Israel Medical Center in Essex County, New Jersey.
All right, Dr. Court, please.
James Court. I'm based at East Orange, New Jersey. I work with these esteemed guys at Newark Beth Israel Medical Center. My specialty is internal medicine, adult medicine.
Dr. Jordan Garrison.
Hi, once again, Jordan Garrison. I'm a general vascular bariatric surgeon, board certified. My office, I specialize in vein disease, and my office is up in Hackensack, New Jersey, with Metro Vein Centers.
Excellent, excellent. Dr. Patrick Anderson, please.
Hi, everyone. I'm Patrick Anderson. I'm a GYN oncologist, board certified in obstetrics, gynecology, and GYN cancers. I work with these esteemed physicians, Newark Beth Israel Medical Center, Essex County, New Jersey.
All right. And Dr. Kevin Clark.
Good afternoon, Dr. Kevin Clark. I'm a surgical oncologist. Happy to be with these guys today.
All right, thank you. And I'm Dr. Omar Bey, pulmonary critical care, subspecialty in nutrition. And so glad to be here with everyone. Just would like to say that we are here every second Saturday. I must preface that to say next month we will not be here because I can't make it. I've got to go to a wedding next month, so I am. I'll be away. So we will put that up on our website. That in May we will miss May, but we will be back in June, and we look forward to everyone joining us then. So every second Saturday except next month, and please note that. If you would like to see our past webinars, just go to OBHealthy and hit the YouTube sign, or click on the little little video, I should say, video camera in the doctor's page, and you can view all of our past webinars. Please, and this is my take on this. Please do not change any aspect of your medical care until you consult your physician, because truly only your doctor can truly take the best care of you from a medical standpoint. All right. All right. I think we're good here. We're going to start again, but what I'd like to do is I'd like to answer some questions, and I know that some of the doctors have been answering the questions while we go along. There was one. There's one question that states they need a doctor, and I hope they're talking about a primary care doctor for a checkup, and they live in New Jersey. So, Dr. Court, we should tell them that you're a primary care doc and would love to
correct.
keep them in the office, I'm sure. So they should please, offices in East Orange, New Jersey. That's James Court, and I'm sure that you can YouTube or not YouTube, but just go on the web and get his phone number and just give him a call. Dr. Court is
They,
always
they will
available.
be welcome.
Yes, always available. Okay. Okay. The next question is, can one have a stent and a pacemaker?
Okay, I suppose that may be aimed towards my specialty.
Yeah.
We spoke about stents before, and we're aware then that stents are located or placed in the arteries, we call them epicardial coronary arteries, and the arteries that run on the surface of the heart. The pacemaker is used for an entirely different rationale and is placed inside the heart generally. In other words, the pacemaker is an electrical device. There's a lead which is placed, one or more leads may be placed inside the heart and stimulate the heart muscle. So the essential purpose of the pacemaker is to increase the heart rate in patients who are predisposed to having slow heart rates, especially if they're symptomatic, if they are impaired as a consequence of the slow heart rate. So the pacemaker function is entirely different to that of the coronary stent function. Okay, it is possible, therefore, to solve or to take care of both of those problems independently or together by the use of one or both of those devices. Okay.
Oh,
One quick
excellent.
question.
Go ahead, Dr. Court.
For Dr. Athley, you mentioned that there are stents. Are there different types of stents? Are there any sometimes medications left in the stent that can help with the treatment of coronary artery disease?
Yeah.
Or it's just to keep the blood vessel open?
Good point. The stents have evolved over a number of years now, and certainly in trying to improve their longevity, improve their overall function, improve their ease of deployment. So many things have occurred with the stents. But one of the points that I would like to make that answers your question is in terms of whether or not there are chemicals or whether the stents are treated in some way to help in reducing the consequences of possible thrombosis or clotting off. One of the most dreaded complications of putting a stent is acute thrombosis. That is, a stent may be placed, and then in the acute phase, that is shortly thereafter, days to weeks, these clots may form in the stent and close the stent off. And that event can cause a major heart attack. What we do now, first of all, we're better at deploying the stents and placing them properly in the wall of the artery. But secondly, the stents themselves are coated, drug coated. So that is one of the newer innovations in the stents, not just a plain metallic stent. The bare metal stents were subject not only to thrombosis, but also we were concerned about the presence of inflammatory processes causing laying down of tissue in those stents as well. But now with the drug-coated stents, we can reduce the incidence of both of those.
Now,
However, you replace one disease process with another.
Mhm.
And what you have to do is give the patient medication to prevent those complications occurring over a period of, well, varied. Most of our studies have shown that we give platelets, dual antiplatelet medications, that is things that reduce the platelet clumping together in the region of the stents. We've given 2 of those over the course of 1 year as a standard. Now, there are many studies that suggest we can get away with as little as 3 months or even less. So we may not have to give the medication for as long a period to help preserve those stents in position while the body heals and encompasses them as a part of its own.
Excellent, excellent. All righty. Thanks for that question, Dr. Court. The second is, and there is another question, should you exercise slowly and can I get a program? Well, I think they're talking about either or, the cardiac or the peripheral artery disease. I know that there are cardiac exercise programs, that is for sure, just like pulmonary exercise programs. Can you get into that a little bit, Dr. Atherley and Dr. Garrison, about the peripheral vascular disease? Do they recommend exercise? And are there official programs for those?
Okay, I'll go first on this. I think it's not just exercise, but I think it's diet. And having done obesity surgery and you doing your obesity medicine, I'm gonna let you answer the diet part of that.
Mm-hmm.
The exercise part for peripheral vascular disease is treadmill. It's a start with a treadmill. You don't want to go out and try to run a mile and you've never run a mile. So it would be slow progression, start with walking. And let's talk about the 10,000 steps. Let's make some clarification about that. The 10,000 step number basically came as a advertisement ploy for some Japanese company. And there's no real scientific evidence about 10,000 steps. I think the evidence points that 7,000 to 8,000 steps is adequate. Somebody chime in and correct me if I'm wrong, but 10,000 steps is an arbitrary number and really has no scientific correlation. So it would be a slow, progressive exercise regimen for claudication. Again, we're talking about increasing the number of mitochondria. And an interesting fact is, and Kevin has had this experiences when we were doing our vascular surgery rotations, is that there is no real significant surgery that corrects claudication. Claudication is corrected through exercise, dietary modification, and cessation of risk factors. And with that, Dr. Atherley has more information about a cardiac rehab.
Yes. First of all, the answer really depends on cardiac rehab from what? From a heart attack, from merely angina pectoris, from open heart surgery. It all depends on what we are rehabbing from. And then the question of what, how often, etc. So it's a very complex question. I would suggest just in broad therapeutic terms, broad terms. Essentially, exercise is beneficial in patients who have cardiac disease. Clearly, in primary, that is preventing the heart attacks from occurring in the first place, and secondary, those who've had heart attacks or open heart surgery, preventing recurrence of the events. We do have cardiac rehab programs, which we utilize in some specific instances where patients can be trained to participate in exercise, usually 3-4 times a week, participate in structured and supervised exercise programs, where we can measure some of the parameters that show us how the heart is doing. They're exercising, we do the blood pressures, do pulses, etc. And they're trained therapists who observe them over the period of time that this is being done. That can be done in various phases, stage 1, stage 2, stage 3, etc. And ultimately, the patients can be taught to just go and exercise on their own with limitations as may be given to them by the exercise physiologist. I think that many patients will not absolutely require that, and sensible exercise may be acceptable for most patients who have some degree of cardiac disease. And that is exercising when and how often. Obviously not exercising immediately after a heavy meal, usually an hour or so to pass. Exercising at least 3 times a week. We don't like those Saturday morning athletes, for example, who don't exercise for the entire week, but on Saturday morning, they think they can go and run 5 miles, etc. That's not the way. We recommend that it be properly structured and given at routine times so that they can exercise at least 3 times a week, preferably 4. The degree of exercise, usually aerobic type exercises, walking, maybe running when you get to that level, swimming, etc., bicycle riding, that these things may be good aerobic type exercises. And nowadays, the American College of Cardiology and the American Heart Association both believe that, unlike what had previously been frowned upon before, that it is good to use weights or strength training exercises as well, not merely the simple aerobic exercises. So a mixture of exercise done frequently enough and done obviously after a period of either structured supervised exercise or long enough after the surgery, the open heart surgery, or the heart attack have occurred.
Excellent, excellent. And when we talk about exercise for weight loss as well, you know, walking is probably the best exercise on a during the week, as you stated, 3 to 4 times a week, walking approximately 15 to 20 minutes. And this type of exercise, when done on a regular basis, really does help. Number one, it helps as far as weight loss is concerned, not that, but also just basic physical activity, just doing that enables our bodies to be more functional. When you're talking about weight loss, you're talking about people that are larger than they should be for their height. And this is a lot of strain, a lot of dynamics, I should say. We're talking about usually an older person that may have osteoarthritis and other things going on, so that exercise may be a little difficult. It's difficult to jog. They can't jog. They can't lift weights. And I know, as far as pulmonary is concerned as well, these patients they're not able to do the physical weight bearing and weight lifting. So we let them walk. We let them train them how to breathe, how to inhale, how to exhale. What to do if they do get short of breath. Those type of things are very valuable as far as pulmonary rehab and pulmonary exercise. So just trying to think of things that would be helpful for the audience. But if there is a need for exercise from a pulmonary standpoint, pulmonary rehab is something that should be considered, especially if you're oxygen dependent, or if you, upon very light exercise or minimal exercise, you become significantly short of breath. Pulmonary rehab should be considered, and you should ask your doctor about that. All righty.
Court
Omar,
has a question.
Omar,
Question?
Yeah, Jordan, let Dr. Court do his question, and then we're going to get to you. Okay?
okay.
Go ahead, Dr.
Just
Court.
okay. Just before we leave claudication, during this conversation, really, how can a patient tell me that they have claudication? What symptoms would they describe, and what does it suggest?
Claudication? I'm sorry.
Yes, sir.
All
Yes,
right.
for claudication.
Claudication, it's again, an activity is performed or a stressor is performed, and with cessation of the stressor and a period of rest, it goes away. So for instance, let's talk about in the leg, and I use the example of a person walking in the mall. They walk from Macy's to Nordstrom and they get pain in the back of their leg. It's usually going to be in the calf. Sometimes it's buttock claudication, and that's a different vascular problem. If they stop walking and sit down for a little bit of time, it'll go away and they can get to Nordstrom's. That is called claudication. Now, disabling claudication is what we concern ourselves with in vascular disease, is that it was an indication that there might be a more severe problem. Is if that person is walking and they get the pain, but they need to get themselves out of danger and they can't do it because of the pain, that's a disabling thing. The mailman that can't run away from the chasing dog, that's a problem. If it's affecting your ability to do your job, that's a problem. Or if it's affecting your lifestyle, that's a problem. And more intervention needs to be addressed. There's such a thing as intestinal claudication, where the arteries that go to the intestines may be affected. And that will happen when a patient eats a big meal or even a small meal and they get gut pain. It'll go away after the food and the nutrients because you need increased blood flow for digestion. After that digestive process stops, it will go away. If
So,
it persists, then you may need intervention with that. You
and it
know,
does suggest that there's some form of blockage, right?
yes, it is. Superior mesenteric artery, inferior those are syndromes that we address. Wilkie's disease, things of that nature. Omar, I really would like to move on to venous disease.
Okay.
This way we can kind of get to some of the other topics like DVT or pelvic congestion syndrome, so we can get Dr. Anderson to give some comments.
Right.
So I really would like to get into that, and we can ask some more questions afterwards, if you don't mind.
Yes, we'll move forward right now.
Okay. All right. We talked about the delivery system, and that's the arterial system, which we know is affected by high blood pressure, cholesterol, and diabetes. We didn't even really get into the difference in diabetic vascular disease. But I want to talk about venous disease, which is the return of blood to the heart. And that can be factored in, as I alluded to Dr. Anderson, there's pelvic congestion syndrome. There are other entities that in trauma that Dr. Clark and I experienced, that no matter how much blood we put into the leg, if we don't get the blood out of the leg, our interventions for arterial disease will fail as well. So with venous disease, we can break it down into chronic venous stasis, varicose veins, spider veins, and again, deep vein thrombosis. Next slide, please.
Okay.
Okay. Now, the venous system, as in blue, arterial system in red, mirrors the arterial system or the delivery system. And basically, blood is delivered. The body uses the oxygen for its metabolic functions. It goes through capillaries. The capillaries are like a diffuser because the artery system is a high pressure system. The venous system is low pressure. Arteries may be up to 120 millimeters of mercury. Venous system is 6 millimeters of mercury or less. Okay, so it goes through the capillaries, the pressure is reduced, and then the blood is in the venous system. The primary function to get the blood back into the heart is the calf muscle pump, ankle calf muscle pump. Moving your calf through exercise such as walking or running gives rise to the blood going back up. That pumps the blood going back up to the heart and the lungs to be reoxygenated to go back through the circulatory system. That's how it works. Next slide, please. Okay, this is on a level where we're looking at if the skin is the outside of the leg and the leg is like a pipe. Through the dead center of the pipe is the major vein called the femoral vein. Underneath the skin, you cannot see these, are other veins called the peripheral venous system, greater saphenous vein, the accessory saphenous, the lesser saphenous. The blood goes from the skin veins into the peripheral veins, and then it goes across through perforating veins into the central deep vein. It's a one-way system. And the reason it is a one-way system is because inside the peripheral and the perforating veins or the crossing veins are valves. They are one-way valves. The blood goes through the valve is closed, the blood cannot reverse direction. So it's up, across, and out multiple times, multiple levels in the leg. We're talking mostly in the legs. And these are pictures of what a vein looks like. They're two leaflets, and those work in conjunction to let only the blood to go upwards. It should not reverse direction. Next slide, please. Symptoms of venous disease. what happens is those peripheral veins and those bridging veins dilate out. Venous disease affects 30% or more of the world's population. It is underdiagnosed and it is undertreated. When we were doing our surgical training, we would spend 95 to 99% of our day dealing with arterial disease. With venous disease, we spend about 1% of our time. We'd say, okay, put a wrapping on it, put stockings on it, and send the patient on their way, or we'd strip their veins out. That's Neanderthal, it's prehistoric. We do not do that anymore. It is an entity upon itself. It's what I do on a day-to-day basis, and it's what I am excited about. So when the arteries dilate, the valves pull apart, and therefore there's a gap in between the valves. And although these valves are fully functional, the blood can go up and it also comes back down. When it comes back down, aided by the effect of gravity, it can leak into the tissues and give rise to an inflammatory process. That inflammatory process can be manifested as swelling. It can feel heaviness, especially as your day goes long. Your legs feel heavy, they feel fatigued, they feel tired. You can get pain, you can get cramping, itching, burning, or even numbness. And at night, when you lay down and your legs are sort of being aided in draining the blood out, the nerves which have been compressed come back to life. So all of a sudden, you're restless. All of a sudden, you can't get comfortable in the bed. All of a sudden, you're kicking in the bed uncontrollably. You don't know why. You can also get cramping. Most of the times when people complain to their doctor about this, they think it's a primary nerve problem. But 90% of the time, it is not a nerve problem, it is a vein problem. And so therefore, when they go to these neurologists and get put on Neurontin or gabapentin, it really doesn't address the primary cause. It addresses the symptoms, but not necessarily the primary cause of they have insufficiency and the blood is going backwards in their legs because of a primary vein problem. Some of the other things, you can get thickened skin around the ankles. You can get darkening or redness called color change. And typically it is called hypertrophic hyperpigmented, high thickness, high color. Next slide, please. Okay, we've already said risk factors. Once again, smoking, #1 risk factor. But this is a hereditary disease that 50 to 60% of the people that have this, if you talk to them, they have a family member that says, oh yeah, my grandmother, my mother, my father had these big ropey veins on their legs. 80% of the patients that come in my office are female. And the reasons they come are different. They'll come because of cosmetic appearance or sensation. Men come because it looks ugly. And their wife is telling them, hey, you got to get that fixed. You know, you're ugly looking. Obesity is the second major cause of that, because as you are obese, you have increased girth, increased belly, and it's pushing down on those veins. So it can cause this problem. Some of the symptoms that you may see from obesity or pregnancy, and Trevor, I'm sorry, not Trevor, Patrick, you can attest to this. You can get labia swelling. You can get veins around your labia. You can have dyspareunia or painful intercourse. And, you know, we may feel a little shy about asking our patients this, but one of the questions I have to ask our female patients are, if I see veins in the upper thigh or inner thigh, it's like, how is your sexual life? Are you having painful intercourse? And you'll be amazed at how many people will say, yes, this is a problem. And we have labia swelling. And so, you know, Trevor, I'm sorry, once again, Patrick, you know, if we'll give you an opportunity to weigh in on pelvic congestion syndrome as well. Nutcracker syndrome, those types of things that veins cause in the pelvis. There's something called Virchow's triad, and Omar is going to talk about pulmonary disease or pulmonary embolism. Virchow's triangle is something that we look at that causes clotting. Venous insufficiency is different than clotting. It's actually the opposite, is that you got too much blood in the vein, whereas clotting means that the vein is blocked off and it gives rise to some other problems. But the reasons for clotting is, there are three reasons called stasis, hypercoagulability, or trauma. The stasis comes from slow blood flow. Hypercoagulability means thickened blood. Usually that means the patient is dehydrated. They have not kept up their water balance, or they have a primary blood problem. And we can talk about polycythemia vera and some other glucose 6-phosphate deficiency, things like that that cause thickened blood. And then trauma. The primary reason of trauma is when you put a patient on the operating table, that their leg is on a hard pad for a long period of time under anesthesia, which the vessels are dilated and you don't get a lot of flow. So what we do is we have to pad the bed. We have to also make sure that we put compression stockings on the patient so that we're pumping the blood up, because the muscles are paralyzed and not working. The second most common thing is airlines travel or extended automobile travel, because the leg is bent. So the blood flow is being blocked from the knee because it's bent. The other thing is people don't drink on the airplanes, or they drink alcohol. They're not keeping up their hydration, so the blood is now thick and you're not moving around. You're strapped into these confined areas with movement. I recommend that every patient get up and walk the aisle when possible. And for every hour on your plane, drink a glass of water. That helps with that problem. Next slide, please. And again, we talked about the abnormal anatomy, dilation, and when the muscle contracts, instead of just pushing the blood in one direction, it pushes it down as well. Next slide. So this is some typical signs of varicose veins. The problem is not necessarily the vein that you see, but the problem is the dilatation or the enlargement of the veins on the inside of the leg. These are connected to the inside. So when a patient comes in like this and they said, can you take care of this? Yes, we can, but I'm going to direct my interventions towards what's going on in the inside of your leg. Next slide, please. So these are the different treatments: endovascular, laser ablation. We do not just strip veins out anymore. I was saying that's Neanderthal, that's prehistoric in the way that we went about doing that. Radio frequency ablation. These two, the first two, are where we take and put a small catheter inside the vein. They have energy activation, and as we withdraw that activation, it shuts down the vein. The goal of treatment is you have hundreds of veins in your legs. The goal is to eliminate the 3 or 4 bad ones, such that blood is now forced to go through the good veins, which eliminate the signs and the symptoms of what you have. We have a chemical called polydocanol, trade name Varithena, which we make into a foam. We can inject that into the veins. The foam does not travel anywhere, and that causes irritation of the vein wall, which would close down that vein. We have a compound called Venocil, which is essentially crazy glue that we can inject into the leg. The downside of the Venocil is that if you have an extremely thin person, the vein does not get reabsorbed by the body because you have this glue that is made it hard. And so they'll feel a rope inside their leg, and that could be cosmetically or psychologically discomforting to the patient. With the other ones, the veins are absorbed by the body over a period of time. And phlebectomy is the removal of the varicose veins that the sclerotherapy or the other treatments do not completely close off. Next slide.
Oops,
Next
sorry.
slide.
Oh,
Okay.
hold on. That one came up again, Joe.
Okay.
All right, there we go.
Now, a lot of patients come in because of spider veins or these small varicosities on the skin, and they want us to treat them. And the first thing they say is, I want laser. Again, laser is just a technique that delivers energy. And there's multiple ways of delivering energy, and there's multiple areas that we can deliver energy. Kevin may use laser in ablation of certain cancers. Patrick may use laser in the ablation of certain things in the vulva and the vaginal area. I don't know the pulmonary applications or the cardiac applications of it, but for us, there's the internal laser we can use on the inside of the vein, and then there is another laser called Cutera, and there's a couple other companies that make this, that we can actually, on the left, you see this nest of spider veins that we can utilize to get rid of the spider veins. But a couple of caveats. When a patient comes in with spider veins, the first thing I tell them is you're never going to be satisfied. You're never going to return to being 17-year-old with your legs. They're not ever going to look like that. We're going to get great improvement in the way they look. We may even get minimal improvement, but for the vast 90% of patients, they're going to get great improvement. Very few get complete resolution. Also, the need for follow-up, to come back at 1 month, 2, 3 months, 6 months, because there may be some dormant veins that need to be addressed as we reroute this blood. One of the key things is to lower the patient's expectation. The first expectation is that this is not a get-rich-quick scheme. You're not going to come in on your first treatment or your first evaluation, be treated, and go on and live a happy, smooth life. It is evaluation, it is treatment, it is follow-up, and further treatment. So it may take a longer period of time than 1 day to get this right, but it can be greatly improved. Next slide, please. Again, this is just an example of injection of a chemical. We do not use saline injections anymore. We use a chemical, either polydocanol or sodium tetracycline. We do not use the sulfite anymore because of the allergic reaction, high incidence people with sulfur allergies. So we use the polydocanol, which is an inert chemical that only works on the veins. Next slide, please. And these are the results. They're all good results. You have to worry about it coming back again. The coming back again is very, very rare. But the primary thing is the patient comes in for evaluations. We do our history again. We do our physical exam. And then the key diagnostic is an ultrasound or a duplex scan, which is going to show us the bad veins. It's going to show us how big they are, and it's going to show us how much, what's called reflux, how much the blood is going backwards. So that is what venous disease is. That's what somebody asked a question about how to get rid of varicose veins is, one, come in for an office visit, an evaluation, a physical exam, and then an ultrasound. There will be an individualized treatment set up for that patient, whether they come to see me or any other vein surgeon. I would recommend that you go to a vein specialist as opposed to, sorry, Trevor, to a cardiologist who's doing veins in addition to their heart work, but go to a vein specialist. We do this all day, every day, 1,000 times a year. And I think that's where you'll be guaranteed your best results. And that's pretty much it. Compression stockings, they're a good adjunct. The insurance company recommends that you wear compression stockings 3 months prior to any treatment. Again, that's an insurance regulation. I don't think it adds anything, and I think it hinders the patient from getting treatment. And somebody mentioned earlier about the cost of not doing early intervention versus these other diagnostic or non-interventional tools. And I am in agreement, and our vascular society is in agreement, that to tell a patient, well, you got to wear compression stockings for 3 months prior to treatment is just hogwash. It doesn't cure disease. It just prevents early intervention of the disease, right, and the costs associated with that. That's right. What I got on that. And there's some other disease entities thrombophlebitis, Mondor's disease again. So, you know, why don't Trevor, I'm sorry, I keep calling you Trevor.
Yeah, Patrick. Patrick has his hand up.
Yeah, Patrick, why don't you weigh in?
Yeah, so a couple of comments. One, the issue with pregnancy and venous disease, that is more of a hormonal issue where you get relaxation of the smooth muscle within the vessels, as every vessel that has different components in the wall, and the smooth muscle component is sensitive to progestins, which is in generally higher during pregnancy, and as a result, you get this venous dilation, which speaks to increased varicose veins, vulvar edema that Dr. Garrison mentioned, and sometimes increased venous congestion in the pelvis. Now, venous congestion in the pelvis can sometimes happen in a non-pregnant state. Sometimes when there is cancerous growths with compression, sometimes with processes such as endometriosis, which Kevin and I fight all the time with this disease, because I think it's just worse to deal with endometriosis than cancer in many cases. And you get this venous, it's kind of like a varicose vein, but up in the pelvis. And due to orientation and the effect of gravity, you know, you get venous leakage, you get chronic inflammation, and sometimes, you know, we lean on guys like the interventional radiologists and Dr. Garrison to do some embolization techniques, which divert the blood from these conglomeration of veins, and the patients will develop collaterals, or smaller veins will dilate to compensate from the blockage. So you get, over time, improved recirculation back into the in the larger venous system. The other thing I wanted to mention is sometimes when we discuss vascular disease and the roles of arteries and veins, we get the perception that these are just rigid entities, but we need to bear in mind that vessels and nerves themselves requires their own intrinsic blood flow to bring nutrition and oxygen to them. So even though we think of the heart muscle being damaged when it's obstructed, or you know, the skeletal muscle in the limbs, the necrosis, and you get ulcers, bear in mind that, you know, there's a neurologic component that comes with this, because the nerves themselves are damaged from lack of blood supply and oxygenation to that tissue. But also the vessel that's required to carry blood, they themselves develop intrinsic damage because they themselves have poor perfusion. So, you know, that's the conundrum that Dr. Garrison and Dr. Athley has to deal with. Yeah, we can improve the blood flow to a distal part, but we may not be able to improve the blood flow to the vessel itself that keeps it functioning as a functioning biologic entity.
Yeah, true. I think vascular disease is something that we don't talk enough about, and especially from a nutritional standpoint. In the hospital, they call me for evaluation of patients that have just simple things like bed sores, when pressure sores, when someone's laying in one spot for a long time and not rotated appropriately, their skin breaks down, and the reason it breaks down is because that pressure and the amount of oxygen and nutrients come into that tissue is not appropriate, and the skin breaks down, and you cause ulcers. Also, lower extremity ulcerations or wounds, especially with diabetes. Diabetes is one of those, and if Dr. Sprock was here, he would say that, you know, that it's something that really at the vascular level, at the nerve level, diabetes is a problem, and it's a problem in our community, number one. Number two is that the lower extremities really have a hard time getting the appropriate nutrients that they need, because of the vessels aren't able to get that blood to the toes, to the feet, to the lower part of the leg. And that's why diabetes is not the number one for African Americans, is the number one cause of amputation, or either toes or lower extremities. And these are some of the problems that we face as physicians, trying to correct this and do as much as we can for these patients. So when you start talking about vessels and blood flow and getting the nutrients to the proper places that it needs to be, such that these medical problems don't occur, it gets very difficult because we don't have a magic pill to say we can just open up that vessel. We have to start with things like weight loss. We have to start with things like exercise, as we talked about, and just methodically just try to get our patients to understand how important it is, just the little things. For instance, making sure your hemoglobin A1C is in a correct level, making sure that you're not overweight, making sure that you're doing that exercise, making sure that your meals are balanced such that you're not overdoing your carbohydrates, and not burning those calories so that they're not being stored as fat. Just little things over time can preserve our body. And over the years, I've realized that this body is a wonderful, wonderful mechanism, and it will take care of you if you take care of it. So as physicians, we try to bestow this knowledge. Anyone else has anything else to say before we move to another topic?
Omar, I'm still hung up on from looking at things from a cancer perspective, where I always worry about failure to rescue. And before we go down that avenue of failing to rescue the heart muscle or a limb, is how can we do, one, a risk assessment, two, and what screening is there? And I know, Dr. Garrison mentioned for a screening modality to be effective, one, cheap, easily applied, and results that are reproducible, and results and a testing that can be performed in all populations with ease. From a vascular perspective, though, we tend to intervene when there's symptom. We tend to be able to counsel patients when we think they are of a high-risk group, smokers, obesity, diabetics. But is there anything screening that makes sense? And over time, we see this with respect to cancer, right? There's some things that didn't make sense, and as time goes on, we say, well, maybe we ought to be looking at a specific population and doing certain intervention, because in that risk population, it makes sense. May not make sense for the general population, but bear in mind, a high-risk population is in the general population as well, right? So if you can identify that subset, is there early intervention that would skew your thought process in the direction of screening as opposed to intervention?
And from my perspective, I think you answered your own question in essence. I think number one, just a good basic, when you meet your patient and talking to your patient, is just a good history. And we have to really understand how important it is to, number one, family history. Number two, that disease that's called diabetes, and things like being obese and overweight. And I think you answered your own question. Those are sort of the screening aspects that we do and I remember in medical school, the number one thing that they used to teach us is take a good history. And if you take a good history, you're already, on board to take good care of your patient. So I don't think there is a test or a chemical that we can, put out there that's going to give us an answer for this. I think we have to, as physicians, just understand that, our patients, let me put it this way: the body works as a unit, and if something's wrong here, then you can guarantee something else is wrong. And you can, I hate to say we can extrapolate, but we truly can extrapolate. If I know that you have severe coronary artery disease, I'm sure that your carotid arteries have some disease as well, and your peripheral arteries have some disease as well. So it's one of those things where I think you answered your question in what you stated.
I think
if I can just weigh in.
screening, just a quick word. Screening is very important, but convincing the patients that you screen about the dangers of whatever you see that is wrong with their habits, and giving them some hope that changing may make a difference. For example, smoking is one of those things that is almost ubiquitous in terms of the effect it has through many different parts of the body. But I would say that it was interesting to see that venous as well as arterial disease was quoted, both were quoted as being secondary or being caused by smoking. And we also mentioned, of course, the obvious cardiac disease, pulmonary disease, et cetera, et cetera. But patients often try to tell me that maybe they're too far gone and maybe it doesn't make a difference. I've been smoking for 50 years. Now, what difference does it make? So we often try to quote some statistics to them. One suggestion is that from the point of view of coronary artery disease, heart disease, if you stop smoking, you're a smoker, but if you stop smoking for 1 year, you diminish your risk of having a major event from the coronary artery disease by 50%. No, I don't know that controlling any of the others has as immediate or well-documented effect. And if you stop smoking for 10 to 15 years, it is as though you never smoked. Your risk factor, your risk of smoking will now be that of a non-smoker. So I sometimes try to convince patients that we do have some evidence about what we speak, and that there's certainly hope in trying to do the appropriate things, screen and cut back on those things which are noxious and harmful to the patients.
Well, let me continue to run this race, right? Because I have to keep asking the question. So if you take parallel processes, yes, and we take a smoker who smoked for many years, right? Then we can convince someone to say, maybe we should do a low dose CT scan to evaluate such a person for lung cancer. Yes?
Well,
why shouldn't we do a CTA in such a person looking for coronary artery disease?
can I
Even if they're asymptomatic.
can I weigh in on that? As far as the thoracic and the lung cancer, you're absolutely right. And that is the new way that lung cancer or prevention is looked at. If you got a history, you're getting a CAT scan. Okay, that's changed. The thing with oncological processes, and Kevin could maybe weigh in, is like pancreatic cancer, colon cancer. By the time you got symptoms from that, the disease is really advanced. With arterial disease, peripheral artery disease, your history and your physical can tell you, it can give you symptoms of that disease early on, as opposed to some other disease processes. So if you're taking an adequate history, and one of the things I do is, I don't wait for the patient to tell me. I ask specific questions. For instance, claudication. If the patient's obese, if they got high blood pressure, they've been smoking, diabetic, I go directly to it. It's like, how far can you walk? I don't say, how's your walk? How far can you walk without a problem? I assume they already have a problem. I just want to quantify that and move on. I try to ask simple yes or no questions, because I already know what the disease process does. I know what the symptoms are. So I just want the patient to confirm that they have those symptoms or they don't. So that is my screening in peripheral artery disease. And if I get those types of yes, yes, yes answers, then I'm going to do exactly what you're advocating, is to do a more invasive screening test. But if I'm not getting those types of symptoms, the prevention that you're talking about in this disease entity, because this disease entity doesn't kill. It doesn't have a high mortality until it's progressed real far. But in the early stages of the disease process, there's no real mortality. And so therefore, there is adequate time for prevention. The prevention is cessation of risk factors, stop smoking, lose weight, control your diabetes, control your blood pressure. And so I'm going to refer those patients to their primary care doctor and let them do the magic that they do at that point.
So I think here's what we just did. I think just by injecting and having this conversation back and forth, we've sent the message, right?
Yeah.
We've sent the message. And the reason I say that, Kevin and I, we were at Tumor Board a couple of weeks ago, and we realized about 30% of our new cancer patients coming through the emergency room when they're advanced, right? But then when you go back and you look at these patients, within the last 3 to 5 months, 80% of them have been in the office of a primary care physician for medication pertaining to diabetes and hypertension. Now, the issue is not surrounding diabetes and hypertension. The issue surrounds the same question you're just asking. to develop a risk category of patients who needs to be focused on.
Yeah.
So Dr. Court,
I think
we're
there are
just
many
messing with you.
dynamics. Excuse me. Give you a second. Give me a second, Kev. I think there are many dynamics that, just for instance, for pulmonary patients, they'll come in and I'll ask them a simple question, and it's how you ask the question. Are you short of breath? And they're like, no, I'm not short of breath. But you ask them, well, can you walk up the flight of stairs? And they're like, well, no, I don't
Oh,
walk.
it kills me.
Walk up a flight of stairs. Yeah, because you take the elevator. So
Right.
your normal is to take the elevator now.
Right.
Obviously you're not short of breath because you don't stress yourself. You over time you become very used to what you do, and what you do over time becomes normal for you. So if you can't jog a mile or can't jog a half a mile, well, guess what? You never thought you wanted to jog a half a mile. So that's okay. I'm normal because I can walk around my apartment, but that doesn't mean that you don't have disease. That doesn't mean that you are normal. You're normal for what you think you are. Go ahead. I'm sorry. Go ahead. Kevin, would you? I'm sorry. I thought you had something to say, Kev.
Oh, no. I'm just listening.
You don't have something to say, Kevin? That's unusual.
Right.
So I would emphasize the point you were just making, though. I mean, I suppose we gain something by repetitiveness and repetition. And the point I'd make is this, that sometimes the way we ask questions, we can, in fact, rephrase our questions slightly differently and get the kind of answer that we're looking for. I oftentimes ask a patient in my field, well, have you had any chest pain? Do you get chest pain with exertion, et cetera, et cetera? They said, no, I don't get any chest pain. But I may push them a little further. Do you feel a pressure sometimes, a heaviness, even a chest discomfort that you want to tell me about? You don't call it a pain, but it may be something that we consider the equivalent of a pain. And you can sometimes tease out by rephrasing and questioning the patient slightly differently. You may tease out the kind of symptom that then becomes significant and pushes you into a more aggressive approach in evaluating the patient. Not necessarily the CTA that I think Patrick was asking about, but maybe a stress test, maybe something else to look to see if there's some underlying disease that may be causing those vague and poorly documented symptoms, poorly expressed by the patient. So at times, if we really have certain disease processes in mind, and this may be in a patient who has multiple coronary risk factors, for example, 3 or more risk factors, we become a little bit more aggressive in terms of our trying to search, to dig for underlying disease, which the patient may not easily express to us on his own.
Mm-hmm. True. Excellent. There's and Jordan, you had put up on your slides, and we didn't get to this actually. We had talked about pulmonary embolus. And pulmonary embolus, I just want to touch on it just because he had the slides up, and it's part of vascular disease. And it's something so common that we see in the hospital. I mean, I'm called frequently to evaluate somebody who has shortness of breath, and possibly is it pulmonary embolus. The way I think about pulmonary embolus as a pulmonologist, that if you think about it, there's a possibility you should evaluate for it. And there are certain tests that we do that may indicate that the possibility is stronger, and things like D-dimers, we can send for those little tests, but D-dimers can be positive for other factors, for other reasons. But it's one of the things that a simple blood test that we send, and if it's positive, then we should truly evaluate for a pulmonary embolus. Where do pulmonary embolus come from, and what is a pulmonary embolus? A pulmonary embolus and I'll just make it simple. It's a clot that forms in the blood vessels of the lung that prevent the blood to flow through the lungs so that you can oxygenate that blood coming into the lung. All righty. So if I have my arteries coming into the lung, and a clot blocks that artery, the blood cannot go through that artery so that it can gather oxygen from the lung tissues to push forward and go in through the heart and be distributed throughout the rest of the body. That is a pulmonary embolus. It can be very dangerous. It can cause significant low oxygen in your blood. It can cause permanent organ damage if the blood oxygen gets too low, and it can cause damage to the lungs itself. So these are some of the things that we are very we're very sensitive to. Number one. Number two is, how is it produced? Where do they come from? Where do these clots come from? Most of the time, there's something called deep venous thrombosis, and Dr. Garrison had talked about the deep veins. The deep veins of the the deep veins of the legs develop these clots, and usually it's in the thigh area where the ones that are most dangerous. And these clots a piece of this clot can flick off and travel up the venous system or up the veins, and it comes through the right side of the heart. And when it comes through the right side of the heart, that blood goes back into the lungs. When it goes back into the lungs, these thrombus or these clots get stuck in the arteries there and prevents the blood from flowing and gathering oxygen, such that we can oxygenate the rest of the body. So that's what we're talking about when we're talking about a pulmonary embolus. Okay, so what are the type of diseases that may, or why should it happen, or when should it happen, or what are diseases that it's most prone to happen with? So number one, having surgery. Anyone who's having surgery, and if you're laying in bed after your surgery, there's a chance for pulmonary embolus, because the blood in the lower extremities gets slow and sluggish because you're not up walking around. And as Dr. Garrison said, what brings that venous blood to flowing back towards the heart is us moving around, is those muscle contractions. And if you're not having that, then the blood slows up, and it's more likely to clot. So post-surgery, you want to get out of bed, you want to sit in the chair, you want to move. You don't want to be a couch potato after surgery. Number one. Certain other conditions like cancer. Cancer is one of those conditions that we call hypercoagulable state. And what does that mean? That means that because I have cancer, my blood may clot more frequently or quicker than someone who doesn't have cancer. And if it clots, guess what? Then a piece of that clot can form a pulmonary embolus. It can flick up. Also, heart disease, and Dr. Atherley is full aware of that. Different lung diseases can cause pulmonary embolus just by the emboli forming in the lung, or there are other types of emboli called air emboli and many other emboli or fat emboli from a fracture of a leg or a long bone fracture. That fat that's in the bone marrow can get into the bloodstream and cause an emboli. So there are many things. Also, pregnancy is one that we should understand, that you have an increased chance of pulmonary emboli with pregnancy and childbirth. And of course, my classic example is a big 250-pound guy taking a flight to California, and he gets off the plane and he's walking through the airport, and he faints, and he's short of breath. What happened is that he didn't get up and walk around. He had his legs bent for 5 hours. He developed a clot, and when he got up and walking through the airport, piece of the clot flicked off, went into his lung, and then he got no oxygen to his brain. Instant problem there. So I don't want to take up any more time. I see there's some hands risen. Patrick, do you have something to say?
Yeah, I think, you touched on some of it. When we talk about an emboli and a clot, we need to be aware that we're talking about a blood clot, the blood forming a clot within the vessels. But there's some other things that Dr. Garrison, Clark, and myself struggle with. And it's the same thing that causes vascular disease. These plaques that develop in the vessel, sometimes during procedures that I do, like dissecting a lymph node and manipulating the vessel, some of those can break off and obstruct the vessel to the kidney. So all of a sudden, they go into renal failure, and the patients and relatives looking at me like, well, what did you do? Well, I kind of didn't do anything except for what I went in to do. Dr. Garrison may be trying to alleviate one of these obstruction by doing a bypass, and distal to where he's putting his graft, a plaque breaks up and goes further into the leg and cause the blood flow to the leg to clot off. So now he bypassed the leg, and there's ischemia in the toes. Well, he did what he meant to do. He did it correctly, except intrinsically in the vessel, there's a loose plaque that breaks off. So we encounter these things all the time. But as far as part of your informed consent, you know, we have to make the patients aware that some of these things can happen.
Yeah. Dr. Garrison, was your hand up?
Yeah, and this is a question to you, Omar, and maybe Dr. Atherley can help me out with this. Typically, as you said, deep vein thrombosis from the thigh causes a clot and it can break off. Well, when we do venous ablations in our varicose vein treatment, we cause clots, and that clot should only extend a certain distance. If it extends more, then we put them on anticoagulation to reverse the effects of that. And this is a patient scenario that I had the other day. Is a patient who was 2 weeks out from me doing a ablation in her thigh. She said she had a little bit of pain in her thigh over that 2 weeks, but she was experiencing some shortness of breath, some difficulty on exertion and everything with the pain in her thigh. And then somebody told she needed to go to the emergency room, and en route to the emergency room, she coughed up a huge whopper of a clot. She took a picture of the clot and showed it to me, so it was pretty big. She said immediately the pain in her thigh went away. Now she went to the hospital. They did D-dimers, they did an ultrasound, they did a CT angiogram of her lungs, and everything was negative.
Yeah.
So talk to me about that scenario where you can't find any etiology, but you know she had a pulmonary embolism. And her shortness of breath went away immediately.
Went away.
Yeah. Have you had that experience?
Jordan, I'm going to have to tell you that is a unique scenario.
I'm perplexed.
I'm trying to put it together how you're going to cough up a clot now, and all your symptoms go away. Now, the fact that, understand, a pulmonary embolus can be a pulmonary infarct. If the clot is large enough, then what happens is it obstructs the blood flow to the lung tissue.
Right.
And when the lung tissue cannot get appropriate oxygen, it's called a pulmonary infarct, because you're infarcting, you're actually killing tissue because you're not giving blood to that portion of the lung. In that scenario, yes, we do get something called hemoptysis, which is coughing blood and coughing blood clots. Will the patient all of a sudden not be short of breath, have no chest pain, have no tachycardia,
and feels better?
No, no, they will be worse. So
Okay.
I can't put it together, Jordan. I
Neither
really
can I.
But maybe you have sometimes you have two diagnoses.
Okay.
And that's the only way I can put that together. Dr. Atherley, can you help me out here?
Can you do that?
Certainly can. I agree with your analysis of it. It sounds very much like the patient had an actual infarction or death of a portion of the lung tissue, and when coughing brought up the blood that was associated with that. I cannot see the total disappearance of symptoms related to that, however, but unless there was some psychological component and the patient was relieved at having brought up this blood and feeling that whatever he had that was noxious has now disappeared. That might be one of the components, but to be relieved totally of shortness of breath and of any pain just on merely by coughing up this clot sounds a little bit unusual for me.
Well, it is.
It'd also be unusual for the CT angiogram. You know, it not just looks at vessels, but it looks at some soft tissue components as well, for that to be completely normal.
Yeah.
Did that patient have any like risk factors for DVT?
She was a little bit overweight. Yeah, she was but she was a non-smoker. You know, she wasn't on any medications of any sort. Her blood pressure was slightly elevated, but not. It was like 130 over 80 something. So she was, you know, she was not on antihypertensives. No blood dyscrasias that I knew about. You know, she was a normal walking, talking patient with some venous insufficiency.
no nasal congestion, post-nasal drip, nothing like that. Because, you know,
Nothing.
you can get a little blood and you think you coughed it up, but it was a post-nasal. That's the only,
No. We're perplexed. We are
consideration is 2 diagnoses. Okay?
It's a long way to travel from the lung to the mouth to spit
That's
it
a
out.
long way. All righty. So this has been Jordan. I am so thankful that you put this together for us. This was
Don't let him off the
wonderful.
hook, Omar. He needs to do a part 2, because one of the things I was hoping he would talk about are things like vascular wall dissections, aneurysms, and those kind of things. So maybe at some point we can do another thing on structural abnormalities of the blood vessel.
Yeah, like
Sorry, Jordan.
aortic aneurysm. Yeah,
Yeah.
things like that.
Listen,
That would be great.
can I swipe your insurance card, Patrick, and I'll be more than happy.
You can swipe my charity care card. That'll be okay.
Oh, great, great. So as I said, Jordan, I'm just so thankful that you put it together for us, brother. You are amazing.
Yes, he is. That he is.
Well done. And
Thank you.
I trust the audience enjoyed it and got, you know, just tons of medical information from it and will be healthier in the future because we did this webinar. So thank you very much. What I'd like to say is, hold on, I have to get my action together here. In
We can
closing,
repeat it.
I'd like to thank OBHealthy for allowing us to bring this webinar to you. Without them, we wouldn't be able to do this, and they've always supported us. So thank you for that platform. Remember, our webinar is every second Saturday at 1 o'clock. Also, I just want to reiterate that we will not be here next month because I have a wedding to go to, and I'm just so happy that one of my family members is getting married, and we're just going to have a good time. All right. If you want to look at our past webinars, please go to the website OBHealthy and just click on our YouTube or on the doctor's page. There is a little video camera. Just click on that. You will be able to check out all of our past webinars. Caring and sharing, please let family members, church members, everyone know, because it really does take a village to keep this going. And we just want to build our audience because education, and especially health education, is valuable. All right. The most important thing that I can say today is please do not change any aspect of your medical care until you consult your physician. No matter what we say, only your doctor can truly take care of you from a medical standpoint. All righty. And at that point, I would like to say thank you all once more for being here, to taking your time. I appreciate it. I do not take it lightly. And until not May, but June, and we're going to have an exciting topics for June. We'll post them up on Facebook and our website and all of that. Until then, I'm going to say peace out. Peace, everyone.
Hey, Omar.
Until next time, thank you. Yes.
One monkey don't stop no show. And Patrick raised his hand. He says he'll be more than happy to host next month. He says, I'll do it.
I'll do it. Yeah, I heard it. I heard it.
I heard it.
All right. We shall be here. We shall be here in June. And thank you everyone for again giving up your time. I know how valuable it is, but we're going to rock and roll and educate our people as far as health is concerned. Thank you again. Until next time, peace.
Bye.
Bye-bye now.